Welcome to everybody who's joining us. I'm going to just give it a couple more minutes before we get started to allow more people to get on the call. We'll probably start in another minute or two. Okay, I think we'll go ahead and get started so we can stay on time for tonight to be respecting everyone's time. So welcome everyone to our chapter webinar. Tonight's topic is going to be the latest news on the pediatric vaccines. This webinar is part of a project that the chapter is doing to increase the confidence of pediatricians around speaking on immunizations. So it's a CDC grant that was titled Vaccinate with Confidence. And our chapter is doing several things, including trying to put out a lot of positive messaging on social media, developing some tools for pediatricians, including posters and handouts. Those are available. If anybody's interested, you can contact us. And then having Dr. Sawyer available to speak with us tonight. So just a couple of housekeeping things. We're going to have everybody stay muted. And if you have questions, please submit them in the Q&A. We have some that were emailed ahead of time, and we'll get to those after Dr. Sawyer gives his talk. And there's going to be an evaluation at the end. It'd be a link, and we'd appreciate for everyone to fill that out. There will be CME credit after you complete the survey for 1 hour of CME. So please fill those evaluations out and get your CME credit. So tonight, our speaker is Dr. Sawyer, Dr. Mark Sawyer. We're so happy to have you with us tonight, and we appreciate you taking the time to be here with us. Dr. Sawyer, as many of you know, is a professor of clinical pediatrics and infectious disease specialist at UCSD and Rady's Children's Hospital. And he has been on many committees, including national AAP committees and our local chapter infectious disease committee. And he has also been involved with the FDA vaccine and related biologic products advisory committee and the CDC advisory committee on immunization practices, and is an associate editor of the Red Book, which we all value greatly. So before we get started with Dr. Sawyer's talk, we just wanted to share this little PSA, which was a collaboration of the presidents of various medical societies showing their support of the COVID vaccine. So it's available on YouTube, but we thought it was worth just giving a quick share. Our own AAP national president is part of this video.
Are America's doctors.
America's pediatricians.
We are America's nurses.
America's family physicians.
And some of us
Our grandparents, too. 8 and 6.
And we want you to know.
COVID vaccines are the right thing to do for our kids.
we've looked at a lot of data.
A lot of cases.
But we've learned a lot.
And this is what we're seeing.
COVID vaccines are safe and effective for kids.
My grandkids are vaccinated.
Mine are, too.
Because like you, there's nothing more important to me than keeping our kids safe.
What's not safe
It's getting COVID
is getting COVID.
I am seeing children almost daily that have the coronavirus.
Why take that chance?
This is not something to toy with.
We took an oath to do what's best for our patients,
So we want you to know we trust the COVID vaccine.
for ourselves,
For our patients,
For our kids.
So should you.
we are America's doctors.
America's pediatricians.
All right, here we go. Wondering if the COVID vaccine is right for your child?
If you can trust it.
Want to know what a healthcare professional would say?
well, I represent over 100,000 family doctors.
I represent over 4.3 million registered nurses.
Nearly 67,000 pediatricians.
And we all agree on this.
It's important for all children 5 and older to get a COVID vaccine.
Because we know millions of cases of COVID have been in kids.
In kids,
Kids,
So I speak for pediatricians.
the nurses you know and trust.
the family doctors you see all the time.
We've looked at the data.
We've studied the science.
And it's clear to me
It's very clear.
you can trust the COVID vaccine for yourself or your kids or your grandkids.
I do.
I do.
I do.
I mean it from the heart.
Hey, guys.
That was great. Thank you for sharing that with us. So Dr. Sawyer, you can go ahead and take it from here.
All right, great. Thanks very much. Who would have thought at the beginning of COVID that we would need a PSA to convince parents to get their kids vaccinated? But we're going to talk about that here tonight. Again, as Michelle mentioned, this is part of a CDC effort to improve communication. The specific effort is around COVID vaccines, but the techniques actually apply to all vaccines. And, there is concern that the misinformation and distrust around COVID vaccines is beginning to bleed over to our routine vaccines that we've given for decades. So I think it never hurts to brush up on communication. I had a lot to pack into this presentation, so although it was perhaps advertised earlier as including infection control, I decided I didn't have time for that. So what I'm going to talk about is why we can make the point that vaccines are good and some tips on how to explain that to everybody. I'll give you some specifics around COVID vaccine in particular, since we're going to be doing a lot of communication around COVID vaccine. I'll try to update you on what I know about the timeline for approval for the youngest age group, which seems now to be imminent in the middle of June. And I'll give you what I know about that. And then we'll have plenty of time for discussion at the end. So I'm assuming you're seeing my slides all right, and somebody yell if that's not the case. I have no disclosures related to this presentation. My objectives for you at the end, you'll be able to describe the current recommendations for booster doses that were just made a couple of weeks ago for the 5 to 11-year-old age group. Sort of be able to explain the factors that lead to the concerns about COVID vaccine in particular, but vaccines in general. You'll be able to choose some talking points that will work for you and your patient population to continue to support your recommendations for vaccines, and then address the unique questions that come up with COVID. Again, most of this is focused on COVID, but I'm happy in the discussion to take questions and comments about other vaccines as well. Some of these slides, many of you have seen in the past. I use them a lot to illustrate the impact of vaccines. I think for this audience, most of this goes without saying. The impact of vaccines is really profound. This paper in the mid-20-teens laid out the numbers for how many deaths and hospitalization and illnesses just in the United States that have been prevented through vaccination for all of the vaccine preventable diseases we do. For somebody who trained in the era when we only had a few vaccines and watching the transition to what we now have, it's been incredible to see the near elimination of some of the diseases that I used to see when I was a resident here in San Diego. And of course, you're probably aware we're close to eliminating polio and then hopefully measles from the planet through the power of vaccination. We've been a little distracted for the last 2 years, focusing on COVID and COVID prevention. It's amazing how fast that has moved forward and the success of that effort, and we'll talk more about that. But just to remind you, this is a partial list of things that we hardly see anymore in the United States, or to some extent even internationally, all due to the power of vaccination. To start making the case for COVID vaccines, lots of questions about whether children need COVID vaccines, what age group of children need COVID vaccines, what is the risk-benefit ratio. There's been some information gathered recently to help with that argument. One such example is shown here. The number of cases per year in pediatric age group under 19 just in California. So 640,000 cases with 35 deaths, puts it certainly on par with influenza and significantly more morbidity and mortality than many of our other vaccine preventable diseases. So just based on the sheer numbers, you can make a clear argument in favor of promoting COVID vaccines aggressively. Here's hospitalizations per year in the United States from vaccine preventable diseases. You'll see it once again in the 5 to 11 year age group. COVID is on par with influenza, hepatitis, much more morbid than hepatitis A, on par with what varicella used to do in the entire pediatric age group prior to varicella vaccination. And then this is the same metric, this time for deaths in a slightly different array of preventable diseases through vaccine. And here clearly COVID is leading the list. So I think, those numbers sort of speak for themselves in terms of making the argument for COVID vaccine, including in the younger age group. This slide further reinforces that argument. This is weekly cases of MIS-C by age group. And you can see that the younger age group is most heavily affected, particularly the 5 to 11 year age group, with the total number as of this publication or this assembly of data, which was just presented at the ACIP meeting on the 19th. 3,809 MIS-C cases just in the 5 to 11 year age group, 8,000 cases overall in the pediatric age group. Many of you have seen what MIS-C can do, both short-term and middle term, based on organ system dysfunction and damage that occurs during MIS-C. So that's another compelling, sort of totally separate compelling argument. And then we have long COVID, which we're still trying to understand, but here's some risk factors associated with long COVID. In children on the right are the common symptoms: fatigue, headache, sleeping problems, and the duration of those symptoms, which, as you can see, go on for months. The risk factors, the 5 to 11 year age group and the 12 to 16-year-old age group, are the highest risk for developing long COVID, in contrast to the youngest, very youngest age group. Allergic diseases as a predisposition also seems to be associated. The other things were not statistically significant, but I would argue we're still trying to understand why long COVID happens and what we can do to mitigate it. And the numbers here are also substantial. So all of this, for me, adds up to a pretty compelling argument in favor of COVID vaccine in the younger age group. The question that then comes up for all of us to ask is, do the vaccines still work in the Omicron and post-Omicron era? And of course, it's a moving target. Clearly, the vaccines do not work as well as they used to. Here's a table from the New England Journal a few months ago, comparing in adolescents the vaccine effectiveness overall against non-critical COVID and critical COVID meaning hospitalization, intensive care unit level disease. And the top three lines are from the Delta era, Delta variant of SARS-CoV-2. When the vaccines first came out, they were very effective in the 90% range. In the Omicron era, that effectiveness has gone down, particularly for prevention of all disease or mild or non-critical disease. You can argue that is no longer the target of COVID vaccines, to prevent all infection. So there's a less strong argument to use vaccination to prevent transmission, because the current vaccines don't prevent infection nearly as well as they used to. But as you'll see in this graph, they still do a pretty good job in protecting against critical COVID. And so the messaging and the dialogue has shifted that vaccination is still beneficial. I'll show you some specific data for 5 to 11-year-olds. It's still effective at preventing severe outcomes, meaning hospitalization and death from SARS-CoV-2 infection. And also, vaccines are still effective at preventing MIS-C. Here's data in the 12 to 18-year age group from the end of 2021. So in the red box on the left-hand table, it just looks at the various characteristics of critically ill patients, comparing unvaccinated to fully vaccinated patients. You can see none of those things happened in the fully vaccinated group. And all of the morbidity was suffered by people who were not vaccinated. And in the right-hand table, again, the vaccine effectiveness at preventing a multi-system inflammatory disease, MIS-C, was still in the high 80-90% range. So the vaccines do work. And so that's part of your discussion point with families who come in saying, well, I've heard the vaccines don't work anymore. You have to shift that messaging to say they do work, and explain what you're talking about when you say they do work. What about boosters specifically? Given the new recommendation for boosters, this is data from adults, not in children, but it does show the impact of boosters. Comparing 2 doses of mRNA vaccine compared to 3, the third being the booster dose, for both short and middle term duration, 1 month after the last dose and 3 months after the last dose. And on the left, you'll see the different categories are preventing all infection, preventing visits to the emergency room, preventing hospitalization, and preventing critical illness and death. And as you go down that list, the vaccines become more effective, once again, making the point that the vaccines are still quite effective at preventing severe outcome. They are not effective, particularly just 2 doses, at preventing all infection. But when you give a 3rd dose, that protection comes back, at least temporarily. And so you do get a benefit from a booster. Now, one of the ingredients for us in pediatrics is the background rate of infection, which was published in the media pretty heavily in February and March. The fact that something like 77% of 5 to 11-year-olds had already had COVID. There are some important, and that's correct. And here's a table showing the seroprevalence by age. The most commonly affected group are 5 to 11-year-old children. And the seniors who are taking all of the precautions are actually the minority group in terms of getting actual COVID infection. But you have to keep 3 things in mind when you're looking at data like this. The infecting strain that you got plays an important role in your subsequent protection. So if you were infected with Delta strain, let's say 6 months ago, you are probably no better protected against Omicron than you are if you never got that initial infection. Also, there's a time duration. The immunity from natural infection wanes just as the immunity from vaccination wanes over 3 to 6 months of age. So if you were infected 6 months ago, that immunity may have waned. Even if you were infected with Omicron 3 months ago, your immunity is beginning to wane. And then whether you have risk factors or not is another important ingredient in deciding how much to rely on previous infection for keeping you healthy in the short term. So if you had Omicron 3 weeks ago, you're probably in good shape and you're protected, and you can make an argument that there's no hurry to go out and get vaccinated or vaccinate your patients. But if you had infection 6 months ago, all bets are off, particularly as we get new variants circulating in the strain. So now let me turn to specifically COVID boosters in the 5 to 11-year age group. Again, just recommended at the recent May 19th ACIP meeting. Do we really think this is a good idea? So to get the audience's opinion, we're going to do a quick poll using the polling function in Zoom. So up on your screen should be a question. Do you think we should routinely give COVID vaccine boosters to all children for whom the vaccine is licensed? And a second question will be coming about if you don't think you should give it to every child, are there some subcategories? But please answer the first question. We'll give you 10 or 15 seconds to click the button, and we'll see what this audience thinks about that question. Are we getting any votes, Kirsty? There we go. So a little bit of a split vote, 55% in favor, 36 against. The follow-up question is, if you think only a subset should get a booster, who should that be? Is it adolescents we should worry mostly about? Maybe only adolescents with high-risk conditions, and all children, or all children with high-risk conditions. Do you have a second question, Kirsty, to load up in the polling? There we go. Here's the follow-up question. So please answer that. Those of you who voted that you wouldn't necessarily give it to everybody. And there's not a huge number on this webinar, so we won't make too much of the results, but I just thought it'd be interesting to poll the group to see. All right, let's see what that subset felt. All children with high-risk conditions. Okay, those are all very reasonable positions. Let's talk about why CDC went ahead with a recommendation for boosters. This is data looking at vaccination status among 5 to 11-year-olds. And the peak that we saw during Omicron, with the overall statistic on the right, that despite the reduced effectiveness of Omicron, in the 5 to 11-year age group, children who were unvaccinated were 1.3 times higher likelihood of getting infected than vaccinated children. So the vaccine does have a measurable impact. Next, we looked at hospitalization. So again, this is 5 to 11-year-old age group during the Omicron period. So pretty much mimicking what we should be seeing right now. Unvaccinated children were twice as likely to end up in the hospital compared to vaccinated children. So again, a compelling, significant number of children that benefit from vaccine. And then finally, the older age group, 12 to 17-year-olds, 2.5 times as likely to be hospitalized if they're unvaccinated. So although we've seen a blunting of the effectiveness of vaccine, you can still make the argument that even in the Omicron era, more children benefit than are harmed. And we'll talk about side effects shortly, because that's the flip side argument. And finally, if we look at the number of deaths in the 5 to 11-year-old age group during the COVID pandemic from 2020 to 2022, 109 overall deaths. Although the majority have underlying conditions, there are certainly a significant number of healthy children who have died because of COVID. And so again, for me, these numbers are compelling, and they were compelling for the ACIP committee and the CDC to say the vaccines don't work as well as they used to, but they still work. So let's talk about complications as the side effects as the other consideration in deciding whether you think we should give boosters to everybody. The primary issue that is on most people's minds is myocarditis. So I want to point out that you can have myocarditis from the actual infection, COVID infection. You can have myocarditis as part of the MIS-C inflammatory reaction after natural infection, and you can get myocarditis from the vaccine. So you have to separate all of that, and people tend to lump some of those numbers together when they talk about the incidence of myocarditis. But this publication from April 1st in the MMWR looked at sort of the worst case scenario, which is 12 to 17-year-old males who are the more likely subset of the population to get myocarditis from vaccine. And in the red box is the rate of myocarditis following second doses. And to summarize what that shows is the likelihood that you're going to get myocarditis is 1 to 5 times more likely if you get natural infection or MIS-C than if you get vaccinated. So again, in the worst case scenario with the highest rate of myocarditis in vaccine recipients, you are still better off getting vaccinated. You're more likely to get myocarditis if you're unvaccinated and then get infected. Another way to look at it is the predicted number of hospitalizations prevented compared to the number of myocarditis cases caused by vaccination. So in this slide, presented at the ACIP, 133 hospitalizations prevented, 30 ICU admissions prevented, at the expense of 1 to 2 cases of myocarditis caused by the vaccine. So the numbers are really quite lopsided in favor of continuing with vaccination despite the low risk of myocarditis. The other point to make about that is that the myocarditis that we are seeing, and we have seen cases at Rady, is all very mild. Most of these kids are observed for 24, 48 hours. They go home. There's not much in the way of long-term sequelae. They do have to have some exercise restriction for a period of time, but then they seem to be recovering. What about the effectiveness? Do boosters really work in children? We have limited data on that, but this is the data that was summarized at the CDC meeting. In the right-hand box is geometric mean titers after 2 doses of vaccine, and then sometime later, prior to the 3rd dose, you see that the level of antibody goes down significantly. That's the problem we have after primary vaccination. But with a booster dose, you end up with a much higher level than you even had after the first 2 primary doses. So boosters do work in young kids just as they do in adults. How long they're going to work is a question that we don't have a great answer to. What about side effects with the booster? Again, here's data presented at CDC. The same side effects occur after the booster as occur after dose 1 and 2. Pretty similar rates to after dose 2, which tend to be higher than they are after dose 1. Fatigue, headache, muscle pain, and some fever. So the boosters are no worse than dose 2. They're generally on par. So this is just a quick summary slide of the overall burden in 5 to 11-year-olds in cases, hospitalizations, MIS-C cases, and deaths, a significant proportion of which can be prevented through vaccination. And that's what led to the recommendation. Just a quick side note here, we do still have disparity issues with completion in the primary series. This looks at race and ethnicity and the percent of kids who are immunized. Clearly, we're not doing a great job of getting our youngest population immunized, and we're about to face a similar challenge in the 6-month through 4 to 5-year-olds that are coming up in a month or so. So we need to keep working on these disparities, make sure that vaccine is accessible to all our populations, make sure we work on communicating with all our populations with trusted sources of information. And we're going to spend the second part of this webinar talking about how to do that. So here is the booster recommendation from the 19th of May. Children 5 to 11, healthy children are now should get a booster dose at least 5 months after they completed the primary series. Children who have moderate to severely immunocompromised conditions are already recommended to get a 3-dose series, which is considered their primary series because of their underlying risk. And then they are now supposed to get a booster 3 months after they got their primary series completed, or in other words, after their 3rd dose. I left the original slide that was used at the CDC meeting said 5 months. That's not correct. And there was a correction that came out after the meeting, just so you don't get confused. And to make it even more confusing for adults, the next dose after this, which is currently recommended in adults, but not yet in children, is 4 months after the first booster, you get a second booster. We may get there with pediatrics, we may not, but for now, this is the current recommendation that was just issued. So let's start talking about side effects from vaccines in general and communication around them. Let's try another polling question. Let's say you have a patient in your practice who develops what you think is an unusual reaction to either their COVID vaccine or any other vaccine for that matter. How would you figure out what to do? Who would you call? These are all potential resources that you could use, or you could just decide that if they had what you think is a serious reaction, you're not going to give any more vaccine of that type. Let's do a quick poll. Okay, let's see the results of that poll. San Diego Health Department, they certainly are a reasonable resource. The CISA network, I'm happy that some people know about that. That is a academic resource nationally that can really dissect complex side effects from vaccine. The FDA website is a reasonable place to find out whether the thing that you've observed is likely to have occurred with the vaccine, but they're unlikely to give you too much advice about what to do about it. Or you can, of course, decide just not to give the vaccine. So I wanted to share this polling question as an introduction to the current vaccine safety monitoring system, which exists both for COVID and other infections, and make sure people are clear on the value of the different parts of the system. So right in the center, green on the left, is the VAERS system, the Vaccine Adverse Event Reporting System. That's been around for years. What happens with that data is it gets misrepresented all the time by people who are opposed to vaccination. Because this is a passive surveillance system, anybody can report any purported side effect. There's no cause and effect analysis that goes into that. There's not even a timing factor. You can say, I got a side effect 2 years after I was vaccinated and report that to VAERS. VAERS is a good system for signaling potential side effects, but then you need to do the research to figure out if there's a true association or not. And the best system for that is sort of buried in the right-hand slide. The Vaccine Safety Data Link, or VSD, is a network of primary care provider groups that can assemble data on millions of people quickly through electronic health records to actually determine if whatever signal you get in VAERS turns out to truly be associated with vaccination by comparing the frequency of that event after vaccination in a window of time compared to groups who didn't have that complication. There were some added things built into the COVID safety surveillance, VSafe. Again, this was active surveillance of people who got vaccinated. I hope you participated. You were asked to report your side effects daily at first, and then over time later that may have come from the vaccine. So that's the first time that kind of a system has been rolled out. There are a number of other database systems shown on the right that were utilized to assemble data on COVID vaccine safety. The point I want to make ultimately here is that we have more safety data around COVID vaccines than almost any other vaccine we use, even though we've only used them for a short period of time, because we've given so many doses and we now have all of these systems in place to monitor. So now let's start talking about communication around vaccine safety and hesitancy. There's obviously a spectrum. You live this every day, from patients who are on your doorstep the minute they can get a booster dose of COVID or anything else, to patients who refuse no matter what you say and are never going to get their kids vaccinated. So, most people acknowledge that what we're targeting with our communication messages are the people in the middle who can be influenced, and if guided to good information, will make a decision to vaccinate their kids. Of course, the challenge is the misinformation that is out there on the internet and not being policed or monitored or controlled in any way. You can find all kinds of very frightening things on the internet about COVID vaccine or anything else. And, we do have challenges in communicating about vaccines, particularly COVID vaccine, because it doesn't always work. And that's been heavily publicized in the media. It does have side effects, although they're very rare, but it's sometimes hard to convey how rare they are to the general public. Because vaccines in general do work so well, people lose sight of the reason we started giving vaccines for measles and polio and things like that. It is inevitable human nature to assume that if one thing happened after another, the second thing was caused by the first one, even if it may just be a coincidence. And we have to overcome that tendency all the time. And we have, in at least some populations, relatively low scientific literacy. So trying to promote the science doesn't necessarily work. And regardless of the population you're talking about, emotional appeals tend to resonate more than scientific appeals. Here's just a partial list of some of the real vaccine risks. I put myocarditis at the bottom from COVID. The current estimate of case rates is 10 to 70 cases per million doses, depending on age group and whether it's dose 1 or dose 2, and also certainly a male predominance in those risk categories. But, you know, if you think about 70 cases per million, that is still exceedingly rare, but they get a lot of publicity and it's hard to convey that. I think I'm going to skip this polling question. These are all potential sites for resources and communication, and I particularly want to emphasize the CDC website, because that's where the Vaccinate with Confidence program is being promoted. I'll show you some screenshots from that website, but it has lots of useful information for day-to-day communication with your families, as does the California Department of Health and the Academy of Pediatrics. And I should have included our local health department website as well. So unlike in past years, we have lots of tools that we can turn to communicate, learn how to communicate, and get examples of good communication. We've sort of covered why we have vaccine hesitancy already, so I think I'm going to skip this and move on. This is just to illustrate the temporal relationship association. We all tend to assume that things that happen in sequence are cause and effect. Black cats got a bad reputation a long time ago, and that's continued. Out of that comes all of the things you've heard for years about vaccines and autism and the various components of vaccines that people attributed to autism. You hear that vaccines overwhelm the immune system. You hear that the diseases are no longer here. Fortunately, you're not hearing that about COVID, but you do hear that COVID is not serious, and therefore you don't need to vaccinate. And there's always the component of industry and profit motive in promoting vaccines generally, and that's sometimes a challenge. And then certainly we've heard this a lot around COVID, is the right of individual right of parents to decide what to do with their kids versus the public health need. And that's playing out in mask wearing and isolation precautions generally, certainly playing out in vaccine mandate discussions. So we can talk about that in the discussion if you would like. How can you respond? The good news is that physicians remain the most trusted source of information. Here's a piece from part of the toolkit that's available in the Vaccinate with Confidence website, looking at who people trust to get vaccine information. I'm happy to see that professional athletes are way at the bottom of the list, and that Dr. Fauci is pretty high up on the list, but you are at the top of the list. So again, you have the power to influence your patients probably better than anybody else. There is a clinical report from the Academy of Pediatrics published in 2016. If you haven't seen that, I would encourage you to look at that. It makes a number of points, some of which I've summarized here, including the fact that it's still the minority of parents who refuse vaccines, but it is a potentially growing number and one we have to constantly battle. And most all of you, probably all of you, have seen patients in that category for sure. And it takes time, unfortunately, which is why, again, looking at some of the resources we'll go over can be helpful to find a couple of quick hitting talking points that you might use if you haven't already adopted them to try to get this communication done effectively and efficiently. Overall, these are some main points from the pediatric clinical report, but also reiterated in the materials on the CDC website. You do have to engage in a true discussion and find out what the risks are that the parents have gotten hold of somewhere from a family member or from the internet so that you can address them. You need to personalize the message and not try to generalize. You can't just use science alone. You have to use some emotional appeal, talk about patients you've seen, talk about members of your family who've gotten sick, whatever you've got at your disposal to make it sound real to people. And as has been emphasized for a number of vaccines, you just want to use a presumptive delivery message, which means it's time for your vaccines today, rather than inviting questions first. If they then have questions, you can address them. The CDC enlisted the help of the Ad Council to come up with good messages. And here's a summary of some of those things. Lead with empathy, avoid lecturing. Again, acknowledge the concerns of patients and support the right of parents to make a decision. Don't try to take that away because that usually ends the conversation right there. Provide facts about safety for the patients for whom that will work. I shared some of the myocarditis arguments here today. Include an emotional appeal that your interest and the family's is in alignment with the family's interest to protect the child or the child's family, and get back to things that you like to do again. And don't overpromise, particularly with the COVID vaccines. You have to acknowledge that they don't work to prevent all infection, but keep it clear that they still do prevent serious disease. There is a whole science to communication. That's, the Ad Council obviously has explored that as they try to reach us through advertisements for commercial goods, but those same techniques can be used for vaccine communication. There's a handbook, which I showed the title page of here, that's available at the NIH website, and the link is at the bottom of the slide. That has some good resources. Here's some do's and don'ts from the Ad Council collaborative campaign about things to say. They don't necessarily come as second nature. Don't say that it's a safe, effective vaccine. Don't dwell on the fact that it came out quickly. Use vaccination instead of injection or shot, which has a negative connotation. Don't quote the government or scientists per se. And acknowledge that it's okay to have questions, that lots of people have questions about vaccines. General talking points. I think it is fair to say that vaccines overall are safe. Any vaccine that comes out as recommended by AAP and ACIP from CDC has been through a very thorough discussion of the risks and the benefits, and every time the benefits outweigh the risks, even though there are risks. Natural immunity may be better for some infections if you survive that natural immunity without serious consequences, but unfortunately, a subset of kids don't, and that's the problem, of course, and there's no way to predict who that is. Again, I wouldn't dwell on the herd protection, community protection argument with COVID vaccine because it's not working as well for that. But overall, you want to challenge in a productive way, the source of information that parents are reacting to, try to guide them to more authentic sources of vaccine information that they can go to and take their time to read through as they're making their decision. I'm going to skip through this. Delayed vaccine schedules, still is a bit of an issue. Again, the emphasis here is that we want to protect your family. The way to do that is to get vaccinated as soon as you can, and that you're leaving your child at risk if you delay vaccines. You can punctuate that with some personal accounts from patients that you've taken care of who delayed vaccines and then got the vaccine preventable disease. And then a lot of research and effort is behind the schedule, as I've already mentioned. Here's a clip from the Vaccinate with Confidence website. It's overall a national strategy. It's built on these pillars of building trust, empowering healthcare personnel to communicate effectively. We've touched on some of those techniques here tonight. and engage communities and individuals. And every community and subset of the community needs to be engaged sometimes in a different way. So it's a lot of work. We have to enlist our partners in the community. I don't think pediatricians can do it alone. The school system is one resource for communication. Faith-based organizations is a resource. The health department is using a lot of energy to communicate about vaccine. We really have to approach this in a variety of ways. Now, with regard to COVID particularly, again, we're still hearing concerns about the safety based on how quickly these vaccines were developed. I think, to me, that's a smokescreen because, again, we've given, I don't know, something like 8 million doses of COVID vaccines to young children, and no new significant side effects have emerged. We have given billions of doses around the world. We know what the side effects are. They are myocarditis for the RNA vaccines. They're thrombosis and Guillain-Barré syndrome for the adenovirus vectored vaccines. So we haven't learned anything new in the last 6 to 8 months with regard to side effects. I think I've overdone some of these points, so I'm going to skip to this, which is resources on the CDC's website to promote COVID vaccine. Again, resources for parents, resources for providers. There's videos here. So take advantage of these, share them with your patients, show them in your waiting room. Again, we need to take a multifaceted approach. Here's a specific section on addressing misinformation, which unfortunately continues to prosper on the internet in particular. And this is some techniques on how to respond to that misinformation. There's a field guide, 12 strategies for your community about how to get into the business of getting our communities overall protected. And this again is on the CDC website for the Vaccinate with Confidence program. So again, lots of resources out there. I think I've made that point. We can talk about any specific ones you have found useful or not useful in the question and answer session. I was going to repeat the poll to see if our opinions changed, but I think we'll skip that since we had a pretty even shift and we don't have that many people on to poll. So I'm going to just quickly summarize with the overarching statements that vaccines are good. In general, COVID vaccines are good. Vaccine hesitancy is a significant problem and one we have to continue to address. There's better evidence and tools now for dealing with vaccine hesitant parents, so make sure you utilize those. If we don't, we're going to see outbreaks of vaccine preventable diseases. Again, that's inevitable. COVID vaccine in particular has some unique challenges, and I've shared some ideas about how to address those. I realize I didn't talk about what's coming, so very quickly, the June 7th, the FDA Advisory Committee is meeting on the Novavax vaccine. So I suspect that we will see, from what I've heard, we will see approval of Novavax and emergency use authorization, probably for adults only at first. Then on June 14th and 15th, we're going to meet to discuss the use of Moderna vaccine in the 5 to 11 year age group. So hopefully we'll have a second vaccine product that can be used in that age group. And then on June 15th, we're going to discuss 6 month to 4 or 5 year olds for both Moderna and Pfizer vaccines. So I think by the middle of June, we'll have word from the FDA about whether that indication has been approved. I am expecting that it will be approved. I have not heard of any unique or unusual side effects in the younger age group. In fact, in general, side effects seem to be less of a problem in the younger age group than they are in the adolescent age group. So lots of more communication we need to go through starting in the middle of June as these things roll out. So let me stop there and open this up to questions and comments.
Thank you, Dr. Sawyer. That was very informative. So I actually just wanted to add a couple of comments again about what our chapter is doing. We are offering media training for any of our chapter members who want to actually become more skilled at being an advocate in the community. and being interviewed by media, since Mark gets asked to do that so much, that we would like to train more of our members to be able to answer questions and speak at school board meetings, and just be available to write op-eds and to get more involved on social media as well. So that's a part of what we're doing. Our chapter is going to be hosting a vaccine event in July with the county, with a vaccine bus at a North County location, just to be there to be able to hopefully provide the vaccine for the kids in the 6-month and up age group. So just kind of be looking out for more information about that. So I'm going to just go ahead and ask some of the questions that we got through the email, and then if there's more questions that people are adding to the Q&A, we'll just try to get to as many of those as we can. So there was a question about if there is any data on the risk of vaccine-related myocarditis in teens or young adults who receive a booster or primary dose of the mRNA vaccine after already having had COVID disease. Does that increase their risk?
There is some data on that, and it's not a lot, and I can't quote the specifics, but I am not left with the impression that there's a significant increased risk if you get vaccinated after having COVID. In general, the CDC and AAP recommendations are you should still get vaccinated even if you've had COVID. There is no minimum interval time period that you have to wait after infection before you get vaccinated. And I don't think you would expect any different or unusual side effects in that setting.
Okay. And for healthy children and teens who have already had COVID in the last 6 to 12 months, is there evidence that they gain further benefit from being immunized or boosted? And is the vaccine-induced immunity better than natural immunity?
Yeah, so I covered some of that in the presentation. The answer is yes. And again, it depends on how long ago you were infected and with what strain. But certainly if it's been 6 to 12 months since you were immunized, your immunity from natural infection wanes. And in order to protect from infection and severe outcome, you need a boost in neutralizing antibody, which the vaccine does provide even after natural infection. So that's why vaccination is still recommended after natural infection.
Do you know if down the line there's likely going to be an Omicron specific kind of vaccine that will be coming out?
I certainly anticipate that. The companies are working on that. There's sort of a deadline to have such vaccines available by this fall, which is looming. I didn't mention that there's one more FDA meeting at the end of June, which is to talk about that exact question, new variant vaccines and what they should look like. I think we're likely to see a bivalent or trivalent vaccine, which includes not just Omicron, but the older strains as well, because they're still around in very small numbers, and variants may emerge that look more like Delta than look more like Omicron. So stay tuned. I'm hopeful that we will have a new variant vaccine by the fall.
Does it seem like it's going to be likely like a yearly vaccine the way the flu is?
I refuse to predict.
Okay.
I think certainly if these variants keep emerging, we're likely to need to boost antibody periodically, but with what frequency, it's really hard to judge at this point.
Okay. And what about giving the vaccine with other vaccines? Is there any data about that?
There's a limited amount of data, not as much as we would want. There is no prohibition about giving COVID vaccine along with all of our other routine vaccines. But the truth is there's limited data. So, if you've had a patient who's already had some kind of reaction to DTaP or pneumococcal vaccine, I might split those apart and not take the chance that you're going to add side effect profiles of one vaccine on top of another. Again, this is the kind of thing that the Vaccine Safety Data Link is well poised to study, because they have the electronic health records of adults and children who've now gotten COVID vaccine, either with or not with other vaccines. And I've not heard any reports emerging that there's a combination that's problematic.
Okay. And then there was a question on, is it known what the mechanism is of the mRNA vaccine triggering myocarditis?
I have not heard a clear explanation of that, nor have I heard why the adenovirus vector vaccine seems to cause thrombosis, particularly in adults. So we do still have something to learn about these vaccines and how they work. I think we've celebrated the success of the mRNA vaccines, and that is going to prompt spin-off vaccines for other pathogens using the same technology. So we will gain more experience and find out if it's the mRNA platform per se, or whether it's something about the COVID antigen that's triggering this myocarditis. But again, a lot of attention has been paid to myocarditis, but the rate of myocarditis is actually quite low. In fact, I didn't mention it, but in the VSD, which has looked specifically at myocarditis in 5 to 11-year-olds, they didn't even see a signal at all. It was only other systems that showed some very slight increase in myocarditis in the youngest age group.
Okay. There was a question, kind of a general question, on any suggestions on how to talk about the COVID vaccine when the parents are hesitant and you ask them what their concerns are and their response is just, I don't know. Like where do you even start with that?
Yeah, I think for that kind of situation, you can maybe just rely on the general principles that COVID is out there. COVID causes problems in children. We have a lot of experience with the vaccines. They're generally safe. The risk benefit adds up strongly in favor of vaccination, because if they don't have a specific concern, it's hard to get very specific, obviously, in return.
Yeah. Okay, just a couple of more thoughts on the interval, the three-week interval between the first and second dose versus waiting longer to have a better response.
Yeah, that sort of flew under the radar, but actually a couple of months ago, CDC did shift the language. So for Pfizer vaccine, the recommended interval between the two doses is now 3 to 8 weeks. And for Moderna, it's 4 to 8 weeks. And the reason for that is there was data out of Israel that by waiting longer, in other words, 8 weeks between dose 1 and dose 2, you induced a higher antibody level and you had less myocarditis. So it is perfectly reasonable now to wait 8 weeks between the two doses. I'm not sure what the language will be around the 6-month to 5-year-old recommendation when it comes out, but I suspect it may include this broadening of the interval.
Okay. And any preference between the Moderna and the Pfizer for the 6-month-old to 5-year-olds? Anything you've seen in the data?
No, although from what we've seen in the media, the Pfizer is at least is a 3-dose series, and Moderna may be only a 2-dose series. Although we've learned in our older populations that 2-dose series doesn't really last. You end up with a third or booster dose. So we'll have to see what the specific data is. But in terms of overall effectiveness of Moderna versus Pfizer, I think it's a toss-up. Moderna has a slightly increased rate of myocarditis, but on the other hand, it generates slightly higher antibody levels. So you get what you pay for, but I don't think it really matters for your average patient or practice. You pick whichever one is either cheapest or, well, as we convert to insurance funding for COVID vaccines, finances may become an issue, but otherwise storage and handling could be a reason you pick one versus another.
And they're still not supposed to be sort of interchanged. Like if the Moderna gets approved, then if a child starts the Moderna, they'll need to continue the Moderna.
Well, I mean, that's generic for all vaccines. You're better off staying with the same product, but that language has been loosened now that you can interchange the mRNA vaccines. There's a few studies which actually show that might be beneficial, but I wouldn't do it for that reason, but it's not really considered to be harmful. So it's okay to mix if you come into that situation.
Okay. I think those were all the messages that I had seen in our Q&A. And if there's anybody else who has any last minute ones, you can throw them in there. please fill out your surveys, your evaluations to get your CME. And the webinar was recorded. I think it'll probably be available for people who want to watch it again, and we'll be able to share it in our chapter. So if there are no other questions, then I think we'll end on time. And thank you so much, Dr. Sawyer. And for our staff in the background, Kirsty, Meredith, and Sydney, who are always working so hard to help us in these endeavors.
Yes, thanks very much for organizing this.